some really brief introductions, and then I'll turn it over to Darlene to do the majority of the presentation. So want to just say good afternoon, everyone. Remind you that the meeting's being recorded. I believe everyone knows me. I'm Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission, and I am the manager for this program. I also have on the call with me my colleague, Nena Anyabo, who's going to be running the presentation. She doesn't have a voice today. She has been ill lately, so she will not be introducing herself. Just want to cover some really brief administrative items. Please contact the MHCC team with any technical issues. We sent an email earlier today with the team's contact information. And as a courtesy to others, we ask that you remain on mute when you're not speaking to reduce the background noise. Staff may mute you if there's noise coming from your line. You can always unmute yourself. Darlene will be doing a presentation. We ask that you hold the questions till the end of the presentation. And then at the conclusion, you can either raise your hand or put your question in the in-call chat box. And then we'll sequence the speakers, and we also may call on people to ensure we have a range of perspectives. If Darlene's not able to answer your question during the meeting, we will respond via email after the meeting. So we are going to be offering a round 2 for new practices, and that's largely due to the success of the round 1 practices. So we are currently accepting applications if you know anyone who you think may benefit from this program. So we'll now begin training module 2, managing a population. Next slide, please, Nena. And I just want to do a brief disclosure that these materials are excerpts from the TCPI program, which included 120,000 primary care and specialty clinicians. Throughout the text, you'll find links to resources that we believe are helpful. And at this time, I will turn it over to Darlene to start the training.
Okay, hello everyone. So we're doing the second training. This one talks a lot about population management and care plans, empanelment, lots of things about patient management as a population. And population management is an approach to planning healthcare needs of all of your patients by shifting the focus from an individual patient visit to the entire population. So population management varies on the type of practice, and care delivery includes ensuring each patient has an assigned physician or care team, which is empanelment. And we'll talk about that in a few minutes. Some of you it won't apply to. And then identifying those patients that need that extra help, which is risk stratification, and then planning their care with care planning and making sure that no patient falls through the cracks. And that would be your care management portion. And of course, we're going to use lots of data to guide that improvement because data is king. We have a lot of concepts with the change package, and it's a whole. It's not one thing, an individual thing. It's a group of things. It's a group of what we're doing that will help in population management. Next slide. And this module is going to show us how to apply some of these change concepts to population management in an ambulatory care setting. And we have some links in the section that you'll be able to refer to because Anena sent you all the presentation this morning. And then you'll find some related resources, some valuable resources that you can save and use either immediately or maybe in the future. Next slide, please. So before we start this, I just wanted to let you know, we're going to go through this. We're going to do a practice spotlight. We're going to do questions and answers. And then at the end, we will do the attestation as we have done before. All right, so this talks about empanelment. Next slide, please. So the first step we need to do is define the population that you as a practice manage. Is everyone treated in the past 12 months or in the past 2 years? Most of the time, looking back 2 years is common practice, but depending on your population, you have to see what makes sense for your practice. So example, they give an example here. If your practice is in a resort area, you probably won't assume any responsibility for visitors that come in, be seen, and then they go home and you never see them again. So at the same time, managed care organizations sometimes assign patients to your practice that you have not seen, but you still should include them because they're part of the population. So once you choose the best definition of the practice's population, then you can assign a patient to a specific provider, which is known as empanelment. Empanelment is the first step in building a relationship between the patient and his or her provider and associated care team. So it's not just her provider. It may be the medical assistant that works with the provider, the nurse, one of those things. And if it's empanelment in a single practice where there are no other providers, empanelment does not apply. Next slide. So for advice on how to empanel patients, there's the American Medical Association has a Steps Forward program, and it's called Panel Management Toolkit. And so after this presentation or in a couple other days, you will be able to click on this link and go to those management toolkit. So empaneling each patient to an individual provider means the provider and her team, his or her team, assume responsibility for a specific group of patients served by the practice. Once they're assigned, the practice can make sure that the patients are seen by those assigned providers. Now, of course, if you are a solo practitioner, you don't need to empanel your patients. I believe that, Lisa Hugh, as you have many providers, and so empanelment might be something that you want to do. And I believe that in some ways you already do that. So maybe you want to divide your practice up into patients with diabetes and have a specific nutritionist work with them, patients with cardiac issues, patients with other kinds of cardiac issues, patients that are, I think you do bariatric surgery patients as well. So empaneling those patients and making sure they see the same provider makes for consistency of care. Next slide. And then we want to talk about risk stratification and care planning. So risk stratification, there are patients in your practice. Some are low risk, some are medium, and some are very high risk. And in order to do care planning, you need to know what category they belong in first. Next slide, please. So you need a method to differentiate those specific types and intensity of care. And that means having some kind of consistent approach to routinely assess the needs of the patient and a plan of care for each patient that supports those particular needs. This is known as risk stratification, and there are standard tools that you can use. Payers use sophisticated tools based on huge data sets, but similar options that practices can use are also available. The Agency for Healthcare Research and Quality website has a lot of these tools that are available to you, and that can be found in this link that you can click on when you open up your presentation. Next slide, please. So you might choose to systematically assess all the patients, or you might want to start with the smaller scale. You know me and my miniature wins, to identify patients with a single risk factor, like all patients with a high A1C, or all patients who keep going to the emergency room for visits instead of coming back to the office. So for each of those risk levels, you should have some kind of basic plan that can guide the care for the various patient groups and address those unique needs of those groups. Sometimes you have, in practices, you have a large population of patients that are very healthy and need preventative care only. Others, there are chronic conditions that might warrant regular assessment and follow-up. Some others might need a higher level of intervention in the form of care management. And so you have to draw upon where it's appropriate for what level of risk. Next page. Also, before we go any further, I just wanted to mention that at this current time, many of you only have one provider, but this is good information to keep on the back burner should you decide to add a physician extender like a nurse practitioner, or if you decide to add another provider. So this information applies for a lot of different things, and it's great information. So make sure that you're saving this so that you have it for future reference. So when we look on this stratifying risk, first, you want to identify risk stratification and use it consistently, and then assign the responsibility for care management. You're going to implement a standard approach to documenting care plans, and also use some kind of consistent method and adjust the risk status for all the patients into actionable risk cohorts. You're going to use maybe on-site practice-based or shared managers to proactively monitor and coordinate the care for these highest risk cohorts of patients. Maybe a medical assistant can be trained, and that's a great way. It's a great way to utilize medical assistants and to gain their loyalty and to make them feel more a part of the process. Use your patient panel management and registry to support management of patients that just have a low or an intermediate risk. And then you're going to have those patients with the highest risk, and you're going to keep refining their care plan, and you're going to integrate their goals, their values, and their priorities. And you may have to adjust it later to an intermediate risk when they are doing better. And of course, those patients that are healthy and Medicare, you could use those Medicare annual wellness visits with a personalized prevention plan for those kind of Medicare patients. Next slide, please. Also, you need to look at those social determinants of health in risk stratification models. So you have your patients with high risk, and they're not always making their appointments. They're not following the regimen that was prescribed. They're no-showing on their appointments. Social determinants of health are very important in the risk stratification model to identify exactly what is it that's causing those patients not to be compliant in their care plan. So I give an example. Many years ago, I worked in an ophthalmology practice, and we noticed that our glaucoma patients kept no-showing or not showing up, or they weren't really using their drops because they forgot how they were supposed to use them, and they weren't doing it. And open-angle glaucoma is a disease that requires drops 3 times a day, every day for the rest of your life. And so it becomes an issue for those patients. So we tried to find out, why is it that they weren't coming to their appointments, or they weren't showing up for their appointments, or they were canceling their appointments. And we found that in our particular practice, the problem was they had a hard time getting to the office, whether it be that the bus wasn't good, whether it be they didn't have cab money, whether it be that, they had to change buses so many times that it was such a hassle that they decided it wasn't worth it. And so what we did when we looked at that, we bought a van, we hired a van driver, and we scheduled those patients to come in every 3 months, and the van would come and pick them up at a certain time. And they might have to sit in the waiting room for a little bit, but at least they were there and we could see them, and they got their regular care. So we tried to address that social determinant of health. Maybe it's giving the patients that are non-compliant a bus pass so that they can get the bus, so that they can afford the bus, or maybe talking to their families about how important it is for them to come to their visits. So you also, though, have to look at the patient's engagement and willingness to address their care gaps and to help with it. For if they don't want to work with you, it's hard to put that together if you can't get them to be compliant. And so you have to allow for the common sense addition to high risk or risk factor care teams. And there's no algorithm that's perfect. You just have to work through it. You also have to identify a way to graduate a patient from care management when they are meeting their goals, and as appropriate delivery care plan with the patient and the family. And, we talked last training about those critical 5-minute daily huddles to plan care for the day. And those huddles are very important to plan for what's happening that day, to plan with what are we going to address with this patient? How are we going to work with this high-risk patient? And then use the risk level to identify who is the best provider for that particular patient. Next slide, please. And then we are developing these plan of care. So you need to base it on patients' needs, patients' preferences, including all those social determinants of health. You need to develop a patient visit agenda. So when the patient comes in, you're going to go through this, and this. And then you're going to huddle regularly to assess those needs and plan accordingly. Those pre-visit plans will optimize the team for those patients with chronic conditions so that they have all the information that they need in order to address it when the patient comes into the office and assesses that, and that you can assess that need. And make the patients a part of this plan. Make them a part of these development plans. Look at the opportunities. Look at their gender, their age, excuse me, I'm sorry. Come on. Come on. And look at those. Use those panel support tools to identify the services that are due for the patient. Use your reminders, your outreach, your patient portals, postcards, emails, and possibly community health workers when they're available to alert and educate the patients about what kind of services are due. Use those visit agendas to engage in shared decision-making with the patient, their family, and the provider. And maybe the patients can help create forms to list their priorities as to what they're going to work towards. Next slide, please. And then we have to identify and decrease those care gaps. So those gaps in cares are critical. Once those gaps are there, things fall through the cracks, and we want to make sure that remember we talked about in the referral system, we have to close that loop. Next slide, please. So, excuse me 1 minute, I'm going to sneeze. You want to provide optimal care for the entire population by identifying and eliminating those care gaps is the aim of population management. It's a structured approach, and it ensures that people served by your practice receive evidence-based care that you want them to have. And using that critical data for different groups of patients, which defines conditions or characteristics, along with these created care plans for each group, provides a data-driven framework for reviewing and adapting the plan of care to meet those individual patient needs. Next slide, please. So, for example, you might want to choose to focus on patients just with diabetes. By running a report from your EHR, you can group these patients into A1Cs with less than 7, between 7 and 9, or over 9. Patients with the good A1C control, they can be followed every 6 months for their diabetes. Patients that are patients in the middle group might be seen every 3 months or so, and they might need that little extra support. And of course, the ones that are in the high risk group are going to need lots of support. Approaches such as self-management, goal setting, health coaching, group visits are often successful in helping the patients to improve their diabetes control. Those with diabetes in poor control are going to need that high level of intervention. Maybe having group visits, maybe have a diabetes morning where all your patients with diabetes that are over a certain level or between 7 and 9 or whatever come into the office, and you might have Dr. Lisa Hughes might come and do a telehealth or a Zoom meeting with your patients and go over nutrition. And have patients talk to each other, because sometimes when a patient understands, I know I ride the diabetes struggle bus every day since I don't know, for 20 some years. But I ride that bus all the time. And sometimes getting in with other patients and seeing that other patients are struggling, that it's not just you that's struggling, can really help the patients to do a better job with improvement. Team members can access patients who struggle for complicating factors like the social determinants of health or an uncontrolled behavioral health disorder. Whatever that is, you could do that as a group and a health coaching to help your patients to do better. Next slide, please. And for those patients who were really willing to make changes, support such as the diabetes educators, partnerships with community agencies, or a dedicated care manager that can help make a difference. And as the patient improves, the risk level improves, the resources need to taper. And so in this way, those resources are consistently matched to the level of support needed for each segment. Implementing this approach will ensure the patients receive optimal care, and it will demonstrate to the to the payer, that the practice delivers high value, evidence-based, efficient services, which is all part of this transformation program. Next slide, please. So you need to identify those kind of care gaps for prevention or defining diagnosis. In specialty practices, you're going to determine the diagnoses that are appropriate for care gap management and develop registries and reporting to facilitate those kinds of gaps. Also, you can determine what conditions or diagnoses are the most prevalent in the practice and start with those. Schedule those regular meetings or huddles to review those care gaps, and assign responsibility for review of each type of care gap to a different team member. Develop an outreach plan for patients who have those kind of care. And again, I said, just schedule a diabetes day or schedule flu shot days to get people to come in quickly and address patients on those care gap reports. So maybe flu shot day, have an hour in the morning and an hour after office visits just for flu shots to make sure that all those patients, especially the ones that are in a high risk category, have gotten those flu shots. Schedule diabetes in the middle of the day, maybe have a lunch and learn with diabetes with all your high risk diabetes patients, and empower those medical assistants and nurses to review those care gap reports for prevention and to prepare the required referral forms or the vaccines. Next slide, please. So now we're going to talk about a little bit about the next steps in population management. Next slide, please. So one of the big things, and we talked about this when we did the assessments, we talked about them, that once you empanel your patients and you begin that population management, you want to consider strengthening the practice relationships with other providers that patients depend on. And that network might be primary care providers, specialists, social service agencies, diabetes educators, cardiac educators, all those different things make up that medical neighborhood. And when you build those relationships with other providers, you're going to find opportunities to offer a better, more efficient care for your patients. This will help not just because of the care plan and the medical neighborhood, but it helps your practice as far as marketing is concerned. We will, when you do this, you can do those relationships. You can create that. And if you're a specialist, primary care providers like to refer to specialists who communicate with them and let them know what's happening with their patients. Let's go to the next slide. Dr. Hugh just came in and said that she is starting to set those up in medical neighborhoods, which is an excellent source. And she is a nutritionist practice. So establish those clear expectations among the primary care team and specialists and others in the neighborhood, and make sure each one plays a role in that. So let's look at defining the medical neighborhood, what practices are it that you work most closely with. And then you're going to develop a personal and electronic relationship among those providers to ensure that that information sharing happens. So I know everybody likes to do email, they like to text, they like to do chats through their patient portal and all that stuff. But there's nothing like a personal relationship. There's nothing like a personal relationship. Developing that relationship, develop a formal agreement or a compact that defines the needs of all the patients. Formalize the lines of communication with local care settings where patients receive care, and ensure documented flow of information and clear transitions back and forth in care so that everyone is on the same platform. Everyone knows what's happening with the patient, and ensure that useful information is shared with patients and families, and that you partner with the patients in developing the process and the tools that make it happen, because they can help too. And then think about payer disease management and the complex care management staff to help avoid patient and family confusion. Next slide, please. Coordinate your care. So we talked about developing those compacts between primary care and specialists. Assign responsibility to someone in your office, a staff member, for care coordination and referral management. Make sure that that information is happening. Establish that two-way exchange of information within that medical neighborhood. Follow up on all referrals to assure that that loop is closed. Participate in the health information exchange if you can. Use structured referral notes and standardize that information shared and the appropriate referral. So maybe you have a specific referral note that you send to a specialist. Maybe the specialist would have a specific note or a specific request as to what they need sent to their office so that they know appropriately how to treat that patient. And then establish some care coordination agreements with the frequently used consultants. And it doesn't always have to be consultants. It could be a diabetes educator. It could be a class at the local hospital that they have on cardiac rehabilitation, those kind of things. And then have someone track it. Now, I know you're all sitting there thinking there's only so much of us and so much that we can do. And I understand that completely. I totally get it. I understand that there's only so much time and so much staff, but there's really creative ways to do that. We had a phone call with some practices, and they were talking about usage of scribes. So they had those scribes, and those scribes were they were expensive, but they ended up using medical residents. And medical residents came in and they were reimbursed at a low rate, but they were getting experience working in a doctor's office, working in a physician's office, whether it be primary care or specialty. And it helped them, and they were scribing to help the doctor create all of this and make sure it worked. I will tell you that when my daughter was young and she was in high school, there were a few of the students that wanted to explore being a physician. So I hired my daughter to come into the practice, and she did all kinds of things, tracking patients, filing charts, pulling charts, working at the front desk. And so you can get some people to come into your practice to help. You just have to be creative about it. Also, there are medical assistant externship programs where a medical assistant comes into your office for 6 weeks at a time, and they learn how to do hands-on medical assisting, and that is a free program. And so that is a way for you to also think about utilizing some creative way to utilize care to fill these gaps. Next slide, please. And integrate that information from the referrals into the plan of care. Allow your primary care teams to request urgent appointments for specialist consults. When you get that specific, that really close relationship, that personal relationship, you can usually get a patient in quicker. Have a shared plan for co-managed patients, and establish a mutual understanding of the information that should be shared when it's transferred. And especially specialty practices, for each referral, notify the referring care team of the date of the scheduled appointments, as well as cancellations and no-shows, so that they understand what's happening with their practice and their patients. Next slide, please. All right, we're going to pull up the spotlight. Can you pull that up for me? I'm going to pull out my spotlight. As soon as I find it. So we also have a spotlight here, and then it's going to bring it up for us. Okay, so this came in your email today. And so I just wanted to look at this just for a few minutes and talk about this a little bit. So the practice, it was an ENT practice that was having problems with patients, post-operative care patients, who kept going back to the emergency room with issues, and the patients were having complications and they weren't understanding what they were supposed to do, and they were no-showing for their follow-up appointments. And so what they did was they instituted standard procedures for post-operative calls with a set of questions and information for the patients. And then they tracked the impact on patients and families to ensure that that program was patient-centered and met their needs. And then next, they talked about identifying a specific person that was responsible for those post-operative calls and scheduling. And they used like a script to identify the information. They developed a type of reporting system so they could identify the patients in need of post-operative calls on a daily basis. And then they standardized call logging and notes, and they captured that. And they used a patient-centered communication methodology to educate their patients and their families and necessary post-op care. Once they did this, you can scroll down and then to the second page. Once they did that, they found errors that they discovered. The post-operative clinic reduced their no-shows. The ED visits were reduced. They used an after-hours nursing line so that patients could ask questions, but that was reduced as well. And so they felt that it was extremely helpful. So they reduced, in about a year, they reduced a 50% reduction in missed post-op appointments, 33% reduction in post-operative emergency room visits, and they successfully thought that that saved them about $108,000. And that well pays for the person who is taking over for that. And so it also improved staff satisfaction, and the nurses felt really important. And the physicians actually had extra patient time, and it improved their productivity in the practice. So this is something that you might want to look at. And although this is a surgical type spotlight, you can identify this with things in your practice as well and adjust it. So let's go back to questions and answers, and let's talk with everybody a little bit about what they thought about this presentation, what they might want to use, or what they're already using. I know that Lisa had to drop off, but she did talk about how she's working, they're working on setting up support groups with a surgeon's office, and they're working together with surgeons' offices. So first we have Tammy. She's in the top left corner, so she won the prize as #1. So how are you today, Tammy?
I'm good.
Good. So what did you think? And are you doing some things in the office like this? Or do you think this might be something that you might want to institute?
We already do things like that because we have this, it's through our, I guess, our Medicare stuff that we do. It's like an ACO company. They do all of our, a lot of our programs for like admissions into the hospital or the ERs or anything like that. Even if they're not Medicare, they tell us that they're there. So we can follow up on it right away within not even 24 hours of them being discharged, unless it's a weekend. We love that because it tells us that they've been there, because we don't always get the documentation from the hospitals.
Right, and it helps you to nip that in the bud before it gets worse.
Well, it helps us to get them in and follow up and make sure that they are going to, if they need a specialist or if they need other care, to keep an eye on everything. So that's what we like, that part. And it's nice because they help us do everything. Especially
what
with
about,
a lot of
so you don't need empanelment because it's just Dr. Matthew.
Correct.
But what about some kind of like diabetes support group, or maybe working with patients that are having issues with no-shows that need to come in, and looking at the higher risk patients and those kind of things?
The higher risk patients and the people with diabetes, he does them on an individual level. He brings them in every 3 to 6 months automatically, no matter if they have diabetes or if they have hypertension or if they're anything, they're there every 3 to 6 months across the board for all of our patients. And he reviews them individually. And he works on them, on everything with them. We can't, we can only tell the patients to go to the specialist if he refers them to it. We can't force them to do that. And that's some of them won't go to the specialists and stuff like that.
Yep, I hear you. Okay, so let's see who's next. Dr. Pritchard, you're on mute.
Okay.
There you are.
Yes.
Hello, how are you?
I'm fine, thank you.
Good. So do you have any comment about the presentation, or anything that you'd like to see in place, or that you already have in place, or tell me what you're doing?
No, actually, we're totally integrated with our specialists, and the specialists are also work at the hospital. So communications flows very quickly back and forth. Lab work, test results, problems that require admission, inputs from the hospitalists who admit my patients. So the communications, in my opinion, is very adequate and is very complete and very quick.
Yes, you have a really good relationship with your referrals, correct?
Absolutely.
Your referring doctors. You have
Yes.
a pretty good,
I'm
you have a pretty good relationship with them. I know, I remember you telling me that.
very, very close relationship. They
Yes.
call me, I call them, and
Right,
we provide them what information they will need prior to the patient going to see them. Many times I'll make a
right.
referral after the patient has left the office, and I will call the consultant and forward to him my office notes and lab work and imaging studies. So we actually have a very good system of sharing
Good.
information.
Good. How about Rebecca? Rebecca, you're on mute.
Hi,
you
sorry,
go.
lost you for a second. I couldn't hear you. Um,
Okay,
So being in a solo practice, the impanelment strategies don't apply to us, but due to the size of our practice, I think having the groups of patients with similar challenges is an excellent idea and something totally doable for us.
mhm.
I think
Mhm.
it's a very intriguing approach to care. I'm sure doctor would love to do that, gather the groups together.
I feel like when I went to my primary care, they had a little group of diabetic patients together, and
Mhm.
they were similar diabetic patients. So they weren't like some with out of control diabetes and some with well
Right.
controlled and that. And so it was really important, and it felt really good to be with like people that are suffering from the same issue. So that's why I think it would be a great way to do that, and maybe have a nutritionist come aboard, do a little presentation, or be there for questions and answers, or having a diabetes educator from the hospital come in and just do a little thing to kind of talk to the patients. I think that really would help with risk stratification ways to help the patient.
Right. I think any little
It's just a
pep
different
talks
way
we
to
can
do
get
it.
are a
Yes.
great idea.
Okay. All right, Sophia, you're the last one. I think that's you, Sophia. You're on mute. Is it Sophia or Lisa? I think Lisa dropped off. You're on mute, Lisa. I mean, Dr. Montalbanca.
So if they're on the phone and they're muted, there's certain buttons they have to push. Nana, do you know what it is? I don't remember.
And I don't, we can't, I tried to unmute her, but it doesn't give me that option.
Yeah, we can't unmute people.
If they have an iPhone, they need to swipe right to their first screen and then they can tap the button.
Swipe right and
then there'll be a screen that just says you are muted, tap to speak. That's on an
okay.
iPhone.
I hope you heard that, Sophia.
Or try *9. I think that's the other one.
Oh, *9.
I think so.
Okay, well, she hung up. I bet she tried to do it and got disconnected.
No, she has her hand up, so she moved to a different
Oh.
part of the screen. Yeah.
Sophia, can you type something in the chat box?
I think she's actually on the phone, Darlene, so I'm not sure if she can do any of that.
Yeah.
Well, she pushed the hand button, so I don't know.
I don't know, when I try to click over here, it says I need a pin. Where did, okay. All right, well, Anene is going to put in the chat box the attestation. So once you do the attestation, you can drop off the call and I'll know that you're done. It's just like the last time, only this time it's training module number 2. So it's in the chat box, or it's also in the email that was sent to you. And you can do the training, Remember, the CTO information I put in at another time. Anene and Melanie, if you could stay on for 5 minutes after everyone else finishes their